Not all pain patients that get opiates become addicts. There's a potential because all the opiate pain medicines are addictive drugs, and certainly they can, so all patients who are going to receive them should be at least screened and monitored for that. It's very difficult to predict in advance who's going to become an addict and who isn't. We certainly can rely on family history, genetic predisposition, their prior history, any experience they've had before. A classic example is the patient who tells you that when they were given some Percocet for their dental work, that instead of going home and going to sleep on the sofa, they went home and cleaned the house. That patient is going to be much more at risk. Well, there are a number of things. One, we have to continue to do better screening, better monitoring, follow-up, watching the patients. But the other thing that we have to do at this point is really look at how we are prescribing the opiates and are they really helping the patients with chronic pain. There's no question they help the patients who have acute pain, but in the long run, are the patients with chronic pain who are receiving chronic daily opiate therapy actually benefiting from it? Trying to reduce the percentage of patients who receive opiates and prevent them from becoming addicts involves doing a good job screening ahead of time, continually monitoring, assessing the patient, as well as reassessing our whole opiate prescribing paradigm. The UF pain care model is different because we incorporate addiction specialists in our assessments from the beginning. We assume that these opiate medications and some of the other medications that are used to treat chronic pain have an addictive potential, and so we include an addiction evaluation from the beginning rather than waiting until the patient exhibits signs or symptoms of an addiction and then bring in an expert.